Your doctor celebrated when your blood pressure hit 120/80. A new study says that may have been the worst thing that happened to you. A landmark study published in JAMA Internal Medicine tracked over 15,000 seniors for 5 full years. And what they found? Results that should have made front-page news everywhere. They didn't. Most doctors haven't read it. Most patients have absolutely no idea it exists. And that gap between what the research actually shows and what's happening inside doctors' offices right now is costing people their independence, sometimes their lives. In the next 15 minutes, I'm going to show you the exact blood pressure range associated with the longest survival in adults over 75. I'm going to explain why the standard target your doctor is chasing may actually be dangerous for you, and I'm going to walk you through one simple test. Takes 3 minutes. You can do it tonight at home. That could be the difference between staying on your feet and ending up in an emergency room. And I've spent years breaking down complex medical research into language that's actually useful for real people making real decisions about their health. This one matters. So let's get into it. Drop your age in the comments right now. Just the number, nothing else. And if you've ever felt dizzy or lightheaded when you stand up from a chair or get out of bed, add the word dizzy. You'll understand exactly why that matters in about 3 minutes. Here's the scenario that plays out in doctors' offices across this country, thousands of times every single day. A 78-year-old comes in for a routine checkup. Blood pressure reads 145/88. The doctor pulls up the standard guidelines on the screen, target of below 130 systolic, and reaches for the prescription pad. One medication gets added, maybe a second one a few months later. Over the next 6 months, the pressure comes down beautifully. 124/78. The doctor is pleased. The chart gets a green check mark. Everyone calls it a success. But here's what those guidelines don't account for. That same 78-year-old stands up to go to the bathroom at 2 in the morning. Their blood pressure drops from 124/78 down to 86/54 within seconds. The brain isn't getting enough blood. The room tilts. They reach for the wall and miss. And now we're not talking about blood pressure numbers anymore. We're talking about a fractured hip, emergency surgery, 3 weeks in a rehabilitation center, a cascade of complications that far too often ends in permanent loss of independence, or worse. That perfect blood pressure reading, the one that got the gold star, it may have been the very thing that put them on the floor. This isn't a rare edge case. This is happening at scale, and it is preventable if we understand that blood pressure targets cannot be applied the same way to a 48-year-old and an 80-year-old. The physiology is simply too different. Pause right here and save this video. The fall risk statistic I'm about to share, that's something you're going to want to reference when you talk to your doctor. Save it now so you can find it. Now I need you to stay with me here, because this is the part that's going to sound backwards. And I know it's going to feel that way, because we've all been told the same thing for decades. Lower blood pressure equals better outcomes. For middle-aged adults, people in their 40s and 50s, that's largely true. Getting blood pressure under control in midlife does reduce the risk of heart attacks, strokes, and kidney disease down the road. The evidence on that is solid. But something fundamental shifts after age 75. The research shows that seniors with systolic blood pressure in the range of 130 to 145 actually live longer than those who've achieved the so-called textbook number below 120. They have fewer falls, fewer fractures, fewer hospitalizations, and, here's what stunned researchers, better cognitive function. The group that hit that textbook perfect 120/80, higher rates of dizziness, higher rates of syncope, that's the medical term for fainting, higher rates of acute kidney injury, and a 28% higher risk of serious falls requiring hospitalization. Their overall mortality rate was 14% higher than those who maintained moderate, slightly elevated numbers. Very low pressure, just as dangerous as very high pressure. That is what the research is showing, and almost nobody is talking about it. If you're finding this useful so far, hit the like button. It takes 1 second, and it helps this information reach more seniors who need it. Now, let me explain why. Because once you understand the 3 physiological changes that happen as we age, none of this sounds counterintuitive anymore. It starts making complete sense. First, arterial stiffness. As you get older, your arteries lose their elasticity. Think about a brand new garden hose versus one that's been sitting outside in the heat and cold for 15 years. The old hose is rigid, brittle. It doesn't flex and absorb pressure the way it once did. Your arteries go through a remarkably similar process called arteriosclerosis. When your heart pumps blood into stiff arteries, they can't expand and cushion that pressure wave anymore. To ensure adequate blood flow reaches your brain and kidneys, especially when you're standing upright and blood has to travel against gravity, your body actually needs a slightly higher baseline pressure. That's not a flaw. That's your cardiovascular system adapting to its current reality. Second, baroreceptor function declines. Baroreceptors are tiny pressure sensors embedded in your blood vessels. In a young, healthy person, the moment they stand up, these sensors detect the shift in pressure within milliseconds and trigger an immediate response. Heart rate increases, blood vessels tighten, pressure stabilizes. It's seamless. But with age, those baroreceptors become less sensitive. They respond more slowly. So, if your resting blood pressure is already at 122/76 and your baroreceptors are sluggish, the compensatory response simply can't keep up when you stand. The result is orthostatic hypotension, that sudden, potentially dangerous pressure drop that can send you crashing to the floor. Third, medication metabolism slows down. Your kidneys and liver don't clear medications from your system as efficiently at 78 as they did at 48. A dose that's perfectly appropriate for a middle-aged adult can be excessive for an older one. The medication lingers, its effects are stronger and last longer, and it can push blood pressure into a range that looks fine on paper when you're sitting still, but becomes actively dangerous the moment you get up. 3 changes, 3 reasons why an older cardiovascular system needs different targets. Not as a compromise, as good medicine. If you know someone over 70 on blood pressure medication, a parent, a spouse, a close friend, share this video with them right now. This information could prevent a serious fall. That's not an exaggeration. Now let me give you the specifics from that JAMA Internal Medicine study because the details matter. 15,342 adults over the age of 75, tracked for an average of 5 years. Not cherry-picked healthy seniors, real-world older adults, many with diabetes, prior strokes, heart disease, and varying levels of frailty. The researchers divided them by average systolic blood pressure and watched what happened over those 5 years. The group with systolic below 120, the textbook perfect group, had a 28% increased risk of falls requiring hospitalization, higher rates of acute kidney injury, higher rates of cognitive decline, and overall mortality that was 14% higher than the next group over. The group with systolic between 130 and 140 had the best outcomes across the board. Not the lowest numbers, the moderate ones. Above 150 systolic, problems predictably increase. More cardiovascular events, higher stroke rates. But the finding that stops people cold is this: being too low was just as dangerous as being too high. The sweet spot sits higher than what most guidelines currently recommend for older adults. And that gap is costing lives. Let me put a face on this. You're 76 years old, you go in for a routine visit. Blood pressure reads 144/86. Your doctor is concerned. Guidelines say below 130, and starts you on medication. 2 months later, it's 128/78. A second medication gets suggested to push it just a bit lower. Another 2 months pass, and you're sitting at 122/76. Your doctor is genuinely pleased, and at first you feel fine, but then, gradually, you start noticing things. When you get up from the dinner table to clear the plates, there's a brief moment where the room tilts. When you stand up too fast to answer the phone, you grab the counter without thinking about it. You mention it to your doctor, who says it's probably just your blood vessels adjusting more slowly. Take your time standing up. Nothing to worry about, but here's what's actually happening. Your blood pressure at 122/76 while you're sitting in the clinic. It looks beautiful on paper, but when you stand, it drops to 94/58. Your brain is experiencing repeated brief episodes of inadequate blood flow throughout the day. Every single time you get vertical, and nobody is checking for this, because the sitting number looks perfect, until the night it doesn't go so well, and the grab for the counter doesn't connect. The sitting blood pressure reading is a snapshot. What matters is what happens when you move through your life. And here is the test your doctor should be running at every appointment if you're over 70 and on blood pressure medications. It's called Orthostatic Vital Sign Measurement. It takes 3 minutes. You can do it at home tonight with a standard blood pressure monitor, available at any pharmacy for around $30. Before I walk you through this, if you're finding this useful, hit the like button. It takes 1 second, and it helps this information reach more seniors who need it. Here's the protocol. Lie flat on your bed or couch and rest completely for 5 full minutes. Don't shortcut this. The 5 minutes matter. While still lying down, take your blood pressure. Write down both numbers. Now stand up and immediately, right away, don't wait. Take your blood pressure again while standing. Write those numbers down too. Now compare them. If your systolic dropped by more than 20 points, or your diastolic dropped by more than 10 points, that is, orthostatic hypotension, that is a red flag. Here's an example of what dangerous looks like. Your lying pressure is 126/80. Looks reasonable. Your standing pressure is 97/62. That's a 29-point systolic drop. Your brain is operating on insufficient blood flow every time you're upright, which is most of your waking hours. You might feel fine in the chair. You are at elevated fall risk, and your current medication regimen may be a significant part of why. Write those numbers down. Bring them to your next appointment. Don't ask permission to have this conversation. Just have it. So what should your blood pressure actually be? Here are the research-informed ranges that the evidence supports for different age groups. These are not rigid rules. Your individual target has to be determined with your physician based on your full medical picture. But use these as a framework for that conversation. For adults aged 65 to 74 who are generally healthy and active, a systolic range of 130 to 140 is well supported by current evidence. It provides cardiovascular protection without excessive fall risk. For adults aged 75 to 84 who are relatively healthy, the evidence supports a systolic range of 135 to 145, slightly higher. Intentionally. This reflects the physiological realities we talked about: stiffer arteries, slower baroreceptors, altered medication clearance. For adults over 85, or for those who are frail regardless of age, a systolic range of 140 to 150 may be most appropriate. At this stage, Preventing falls and maintaining quality of daily life often needs to take priority over aggressive pharmacological pressure reduction. On the diastolic side, that bottom number, for older adults, it should generally stay above 65, ideally between 70 and 85. Very low diastolic pressure can compromise blood flow to the heart muscle during its relaxation phase. If your diastolic is consistently sitting below 60, that warrants a conversation with your doctor even if your systolic appears controlled. Let me show you why applying one universal target to all older adults is a mistake, with two real scenarios. Two people, both 81 years old, both walking in with a reading of 158/88. The first person is managing mild heart failure, Stage 3 chronic kidney disease, and osteoarthritis. Multiple conditions, reduced functional reserve. For this person, aggressively pushing medications to hit 120 systolic carries real, serious risks. Pressure that drops too low when standing, medications that strain already compromised kidneys, dizziness that, with osteoarthritis, could lead to a catastrophic fall. A more reasonable target might be 140 to 145, reached carefully and monitored closely. Accepting that number isn't giving up, it's good medicine. The second person is healthy and active, plays golf twice a week. No significant medical problems. For this person, 158/88 probably does warrant attention. But not aggressive intervention. Lifestyle modifications first. If medications become necessary, a low dose, a conservative target, and regular monitoring. Pushing toward 120 here would be unnecessary and potentially harmful. Same age, same reading, completely different approach. This is what it means to treat the patient, not the number. You're probably wondering, if this research exists, why hasn't my doctor brought it up? The honest answer is that medical practice changes slowly. Most of the landmark trials that established 120/80 as the gold standard were conducted primarily in middle-aged populations. When those results were published, the guidelines were applied broadly across all age groups, on the assumption that what's good for a 52-year-old must also be good for a 79-year-old. That assumption is wrong. And over the past decade, researchers have been finding exactly that. But it takes years, sometimes many years, for new evidence to filter into clinical guidelines, and even longer for those updated guidelines to actually change what happens in a 15-minute appointment. None of this means your doctor is wrong or doesn't care. It means the system is slow, and you are in the best position to bridge that gap. Because now you understand the nuance well enough to ask the right questions. Here's what to do starting tonight. If you're over 70 and on blood pressure medications, get a home blood pressure monitor if you don't already have one. Check your pressure twice a day, morning and evening, at the same time each day for 2 full weeks. Keep a written log. Patterns matter more than individual readings. Do the orthostatic test I described, lying down for 5 minutes, check your pressure, stand up immediately, check again. A drop of more than 20 systolic or 10 diastolic is worth documenting and discussing. Be honest about your symptoms: dizziness when standing, unexplained fatigue, difficulty thinking clearly. These can all be signs of blood pressure that's been pushed too low. Even when the office reading looks fine, schedule a specific conversation with your doctor about your blood pressure target, not just a checkup, a conversation. Bring your 2-week log. Bring your orthostatic results. Ask what the appropriate target is given your age, your specific conditions, and how you function day to day. Don't accept a blanket number that doesn't account for who you actually are. And if you're experiencing side effects from your medications, say so loudly and clearly. Dizziness, fatigue, brain fog. These are not things you have to accept as the price of managed blood pressure. Doses can be adjusted, medications can be changed, targets can be reconsidered, but only if you speak up. Do the orthostatic test tonight. Then come back and tell me what you found. Did your pressure drop more than 20 points when you stood up? I read every comment. Tell me. Here's what you now know that most people around you, and honestly, many healthcare providers, don't yet have a full picture of. Blood pressure targets are not one size fits all. A 46-year-old and an 82-year-old should not be held to the same number. For adults over 75, systolic pressure in the range of 130 to 145 is where the research says survival and quality of life are best. Below 120 increases fall risk, kidney injury risk, and possibly cognitive decline. Above 150 increases cardiovascular risk. The sweet spot is in the middle, and it's higher than most guidelines are currently reflecting. You now know how to test for orthostatic hypotension at home. You understand why older arteries, slower baroreceptors, and changed medication metabolism all point in the same direction. And you have the language to walk into your next appointment as an informed, active participant in your own care, not just a recipient of whatever gets written on the prescription pad. That's not a small thing. That's the difference between being managed and being heard. Thousands of people watching this right now are going to have a completely different conversation at their next doctor's appointment. Be one of them. Drop the word informed in the comments. That's all. Turn on notifications so you don't miss the next video. I'm covering 3 supplements that research actually supports for blood pressure and 2 that are a complete waste of money. That one's coming this week. Every video on this channel is research-backed, plainly explained, and built for adults who want real answers, not generic advice. Subscribe if that's what you're looking for. Next video. The supplement industry doesn't want seniors to see this one. Subscribe, and I'll see you there.